Here are 3 things you need to know before we even start today's session. 1. Your ear is not a single organ. It is a Frankenstein construction project made of 3 completely different tissue types that have to migrate from different parts of the head to meet in the middle.
Right.
2. When a baby is born with a defect, the difference between a malformation and a deformation isn't just semantics. It changes the entire prognosis for that family.
Yes, a huge distinction.
And 3, we are going to learn how to read the gray scale of an ultrasound, effectively turning sound waves into a time machine to measure the age of a fetus. Welcome back to the deep dive.
It's great to be back, and today is a bit of a special one because we're not just pulling from a single source. We have a triple threat on the desk today.
We do. We are pulling from the absolute titans of embryology. We've got Langman's medical embryology for the hardcore structural development.
We have a Bible for that, really.
Then we have Moore and Prasad's The Developing Human for the clinical classification of defects.
Which is so crucial for putting it all into context.
And finally, I.B. Singh's Human Embryology to help us understand the imaging, the ultrasound, how we actually see this stuff.
It's kind of the holy trinity for medical students and clinicians. And I want to be really clear right up front. What we're doing today is a synthesis. We're weaving these 3 narratives together to give you the big picture.
Right.
This is an interpretive guide, a revision aid, to spark that curiosity.
Right.
It does not replace sitting down and actually reading the chapters.
You can't stress that enough.
No, that reading is essential for your training. Think of this deep dive as the map. You still have to walk the territory yourself.
We're the trailer. The textbook is the movie. But wow, what a movie it is. Let's start with that first pillar of our deep dive, the architecture of the ear. I was reading through the section in Langman, the chapter on the vestibulocochlear organ, and the complexity is honestly terrifying.
It's a structural nightmare that somehow works. I think to understand the ear, you have to abandon the idea that it's one thing. It's 3 strangers meeting in a dark room. You have the internal ear, the middle ear, and the external ear.
And they come from completely different places, right?
Completely different origins. They come from different germ layers, ectoderm, endoderm, and mesoderm. They develop on different timelines, and they develop at different physical locations on the embryo's head.
And yet they all have to come together perfectly.
They have to migrate and fuse with sub-millimeter precision. If they miss, or if the timing is off by even a day, the chain is broken and you have hearing loss. It's an incredible feat of engineering.
Okay, let's break this down, starting from the inside out. The internal ear. Langman calls this the labyrinth, which feels very appropriate.
The labyrinth is the command center. This is the part deep inside the temporal bone of the skull that handles both hearing and balance. And its origin story is, well, it's pretty surprising. It starts at day 22 of development.
Day 22, the embryo is basically a speck at that point.
A speck. And the inner ear starts as a thickening of the surface skin, the surface ectoderm, right on the side of the developing hindbrain, the rhombencephalon. This thickening is called the otic placode.
Hold on, so the machinery that will eventually let us hear a symphony or balance on a bicycle, it starts as a patch of skin on the outside of the head.
Exactly. But it doesn't stay there. It invaginates. That patch of skin starts to fold inward, creating a little pit, and eventually it just sinks deep into the underlying mesenchyme. It pinches off from the surface completely.
I love that visual. A bubble of skin just retreating into the skull to build a bunker.
That bunker is called the otic vesicle, or the otocyst. So now you have to imagine you have this hollow ball of ectoderm floating inside the tissue of the head. That simple bubble has to differentiate into everything. Langman describes a great divide at this point.
Right. The otocyst splits into 2 distinct components.
Yes, a ventral and a dorsal component.
And they have different jobs.
Totally different jobs. The ventral component is the hearing department. It gives rise to the saccule and, crucially, the cochlear duct. The dorsal component is the equilibrium or balance department. It becomes the utricle, the semicircular canals, and the endolymphatic duct.
Let's zoom in on the hearing part, the cochlea. Because the geometry here is just wild. How do we go from a round bubble to that spiral snail shell?
It's a process of really aggressive directional growth. Starting in the 6th week, that cochlear duct begins to grow out of the saccule like a tubular tail. And it doesn't just grow straight, it begins to spiral. It wraps around itself.
And there's a very specific number here you need to remember.
Yes, 2.5 turns.
Not 3, not 2, exactly 2.5.
Exactly. By the end of the 8th week, the cochlea has completed precisely 2.5 turns. It's like a mathematical constant in human development. If it stops short or if it spirals too loosely, you get what's called a Mundini dysplasia or other structural anomalies that cause hearing loss.
And inside that spiraling tube, that's where the real magic happens.
This is differentiation.
Yeah.
The cells lining that tube turn into the organ of Corti. These are the sensory hair cells. They're basically transducers. Their only job is to take the physical vibration of the fluid in the cochlea and turn it into an electrical spark.
A spark that the brain understands as sound.
That's all sound is to the brain, an electrical signal.
Now, there's a connection that stays between the hearing part and the balance part, right? The cochlea doesn't just float away on its own.
No, it stays connected to the saccule, but the connection gets,
Right.
well, it gets strangled. It narrows down to a tiny, tiny pathway. It's called the ductus reunions.
Ductus reunions. It sounds like a legal proceeding or a diplomatic treaty.
It does sound very official. But clinically, it's vital. Its job is to balance the fluid pressure between the hearing compartment and the balance compartment.
And if it gets blocked.
If that duct is blocked, or if the pressure regulation fails, you can get endolymphatic hydrops, which you might know as Meniere's disease.
Ah, okay.
That's where patients get that horrible combination of vertigo and hearing loss at the same time because the fluids are completely out of whack.
Speaking of vertigo, let's look at the dorsal side, the semicircular canals. These are the loops that tell us where our head is in space. Langman's description of how these form is incredibly visual. They aren't built as tubes from the start.
No, they're carved out of solids. It's more like sculpture via destruction.
How does that work?
Imagine 3 flattened, pancake-like flaps sticking out of the utricle. To make them into loops, the center of each pancake has to die.
Programmed cell death. Apoptosis.
Precisely. The inner walls in the center of the pancake press together and then just dissolve. So you're left with just the rim of the pancake, and that rim forms the hollow tube. That's your semicircular canal.
And at the end of each of these canals, you get a little bulge.
That's the ampulla. Inside that bulge is the crista ampullaris. Those are the specific sensors for angular acceleration. They're the ones that tell you if you're nodding yes, shaking your head no, or tipping your head to the side.
So we have this incredibly sophisticated sensor array built from a patch of skin that just sank into the head. I want to pause on that skin origin, the ectoderm. Why does that actually matter to a doctor 30 years down the line?
It's a huge diagnostic clue. Because the inner ear and the skin share that common origin, the surface ectoderm genetic conditions that affect the skin often affect the ear. They travel together.
Can you give us a concrete example of that?
Sure. Take something like congenital ectodermal dysplasia. You might have a patient come into your clinic with very sparse, brittle hair, maybe weirdly shaped teeth, or problems with their sweat glands. All skin-related issues.
Okay.
If you see those skin issues, your very next thought should be to check their hearing. The error in the genetic blueprint affected the entire ectoderm layer. So the ear, which came from that same layer, is likely to be involved too.
That is a fantastic clinical pearl. Look at the nails, check the ears.
Right.
Okay, let's move outward to the second layer of our Frankenstein monster, section 2. The middle and external ear. Langman calls the middle ear the conductor.
Because its job is mechanical conduction. It has to take sound waves from the air, transfer them through the skull, and get them into that fluid-filled inner ear we just built. And here's where the hybrid nature of the ear really kicks in. The middle ear comes from the endoderm.
Specifically, the first pharyngeal pouch.
Right. And we need to be really careful with the terminology here. Pouch versus cleft. The pharyngeal arches, those sort of gill-like structures on the embryo's neck, have indentations on the inside and the outside.
So an in-pouching and an out-pouching.
Exactly. The inside spaces are pouches, and they're lined with endoderm. The outside indentations are clefts, lined with ectoderm.
So the middle ear is an inside job.
Yes. The first pouch grows outward from the developing throat toward the skin. It forms what's called the tubotympanic recess. The distal end of it widens out to become the room, the tympanic cavity. The proximal stalk, the tunnel back to the throat, stays narrow.
And that stalk becomes...
Eustachian tube, also known as the auditory tube. This is why your ears pop on a plane or when you have a cold. You have a direct embryonic tunnel connecting your middle ear to your nasopharynx. It's a remnant of that first pouch.
That explains so much about why ear infections are so common in kids. It's basically a highway for bacteria from the throat to get right into the ear.
Exactly. And in kids, that tube is shorter and more horizontal, making the highway even easier to travel. Now, inside that cavity, we have the ossicles, the 3 smallest bones in the human body: malleus, incus, stapes.
The hammer, the anvil, and the stirrup?
And their origin story is fascinating because they're essentially repurposed jaw components, evolutionarily speaking. They come from the cartilage of the pharyngeal arches, but not from the same arch. This is the mix and match part.
Okay, lay it out for us.
The malleus and the incus come from the first pharyngeal arch cartilage. The stapes, the little stirrup, comes from the second pharyngeal arch cartilage.
And Langman gives us a brilliant way to remember this using the nerves, right? Because the muscles never forget where they came from.
That is the golden rule of embryology. Muscles drag their innervation with them no matter where they go. The tensor tympani muscle attaches to the malleus.
Malleus is first arch.
So the muscle is first arch. The nerve of the first arch is the trigeminal nerve, cranial nerve V.
And the stapes.
The stapedius muscle attaches to the stapes. Stapes is the second arch, so it gets the nerve of the second arch, which is the facial nerve, cranial nerve 7.
So let's think about a clinical scenario. I have a patient who complains that normal sounds, like a door closing or a fork hitting a plate, are painfully loud. That condition is called hyperacusis.
Right. It implies the ear's dampening system isn't working. The stapedius muscle isn't contracting to protect the inner ear from loud noises.
So you should immediately suspect a problem with
The facial nerve. Exactly. You're diagnosing a potential nerve issue based on a tiny muscle in the middle ear. It's all connected.
Incredible. Now, there's a term in Langman that sounds like a construction project. Pneumatization. What is happening there?
This is the expansion of the airspace. The tympanic cavity isn't actually finished at birth. In late fetal life and early childhood, the cavity continues to expand. It eats its way backward into the mastoid part of the temporal bone.
The big bump behind your ear.
Right. It creates the mastoid antrum, those honeycombed air cells you can see on a CT scan.
And why is that clinically dangerous?
Because it happens late.
Yeah.
That space is new and vulnerable. If a child gets a bad middle ear infection, the pus and fluid can easily push back into those new mastoid air cells. That's mastoiditis. Before antibiotics, that was often fatal because the infection is sitting right next to the brain.
Let's move to the final layer. The external ear. The collector.
Now we flip back to the outside of the embryo. Remember the clefts. The external auditory meatus, the ear canal, is the first pharyngeal cleft burrowing inward.
So the canal digs in from the outside, from the ectoderm, and the middle ear pushes out from the inside, from the endoderm, and they meet at the eardrum.
The tympanic membrane. And because it's the meeting point, the eardrum is this beautiful triple-layer sandwich. The outer skin is ectoderm from the cleft, the inner lining is endoderm from the pouch, and the filling, the connective tissue, is mesoderm.
It's literally the only place in the body where all three germ layers are fused into a single membrane.
It's a perfect landmark for that.
There's a weird developmental hurdle here, though, that Langman mentions. The meatal plug.
Yeah, nature essentially boards up the windows for a while. Around the 3rd month, the cells at the bottom of the developing canal proliferate and create a solid plate of tissue, the meatal plug. The ear canal is completely blocked.
And when does it open up?
Not until the 7th month of gestation. It has to dissolve. And if it doesn't dissolve, the baby is born with congenital atresia or deafness. They have a canal, but it's a dead end.
Finally, the part of the ear we actually see. The auricle, the pinna. It looks like just a crumpled piece of cartilage, but Langman says it's actually made of 6 distinct hillocks.
The hillocks of his. Imagine 6 little mounds of tissue that appear around the first pharyngeal cleft. 3 come from the first arch and 3 come from the second arch. They swell up and then fuse together in a very complex way to form the helix, antihelix, tragus, and all the bumps and folds of the outer ear.
You mentioned they appear around the cleft. Where is that exactly?
Well, this is the other great migration story. The ears start way down in the lower neck region of the embryo. As the jaw, the mandible grows and the face expands forward, the ears are physically pushed upward and backward to their final spot, level with the eyes.
Which brings us to a massive red flag moment for anyone delivering a baby or examining a newborn.
Huge. If you examine a newborn and the ears are low set, meaning the top of the ears below the line of the eyes, it means something went wrong with that migration. It could mean the mandible didn't grow or the whole process was halted. It suggests a global developmental pause.
And because the ears develop at the same time as other vital organs?
You have to check them. The neural crest cells that form the ear also contribute to the heart and are active during kidney formation. Potter's sequence, for example, which is caused by renal agenesis, no kidneys, famously presents with low-set, funny-looking ears. The ear is an external billboard for internal chaos.
That segues perfectly into our second source for today. We're pulling down Moore and Persaud's The Developing Human, specifically the chapter on congenital anomalies.
This is where we need to stop using birth defect as a catch-all term. Moore and Prasad are very, very strict about nomenclature. And for good reason. There are 4 distinct categories: malformation, disruption, deformation, and dysplasia.
I used to think these were just synonyms for something went wrong.
Most people do.
Yeah.
But the mechanism is totally different, and that changes the counseling you give to parents and the prognosis for the child. Let's start with malformation.
A malformation is a bad blueprint.
That's the perfect way to put it. This is an intrinsic error. It happened during organogenesis, the building phase. Usually it's a chromosomal error in the sperm or the egg. The organ was never formed correctly in the first place because the instructions were wrong from the get-go.
Like a ventricular septal defect, a hole in the heart.
A classic malformation.
Okay, contrast that with a disruption.
A disruption is a tragedy of circumstance. The blueprint was perfect, the organ started growing normally, but then something from the outside came in and wrecked the process.
Like a wrecking ball hitting a half-built house.
Exactly. Amniotic bands are the classic example. A strand of the amniotic sac can tear off, float loose, and wrap around a developing finger or arm. It acts like a tourniquet.
It cuts off the blood supply.
And the limb downstream from it dies and is amputated in the womb. That is a disruption. It is not genetic. The parent's DNA is fine.
That is a crucial distinction for counseling parents. If it's a disruption, the chance of it happening in the next pregnancy is basically 0. It was a terrible accident. If it's a malformation, it might be genetic and could recur.
Exactly. That is why the words matter so much.
Okay, then we have deformation. This sounds mechanical.
It is pure physics. The tissue is normal, the genetics are normal, but the fetus is being squished.
Squished by what?
Usually the uterus itself. If there isn't enough amniotic fluid, a condition called oligohydramnios, the muscular walls of the uterus press directly on the fetus. If the foot gets pressed against that wall for 2 months, it turns inward. That's a club foot caused by deformation.
And the prognosis for that?
Usually pretty good.
Yeah.
Since the tissue is genetically normal, if you relieve the pressure after birth and do physical therapy, casting, or sometimes surgery, it often corrects itself beautifully.
Last one on the list, dysplasia.
Dysplasia is a problem with the materials. It's an abnormal organization of the tissue itself. The cells don't stack correctly. This usually affects generalized tissues like bone or cartilage throughout the body.
So not just one part is wrong.
Right. The whole system for making that tissue is flawed. Achondroplasia, the most common form of dwarfism, is a skeletal dysplasia. It isn't just one bone that's short. It's the recipe for making bone that's wrong everywhere.
Moore and Prasad also drop some pretty heavy statistics on us.
They do, and it's humbling. Despite all our advances in genomic sequencing, 50 to 60% of birth defects still have an unknown etiology. We just don't know the cause.
But for the ones we do know about, chromosomal abnormalities and aneuploidy are the big players, and this usually involves non-disjunction.
Which is when the chromosomes fail to separate properly during meiosis. When the sperm and egg are being made, you end up with an extra copy. Trisomy 21 Down syndrome is the one everyone knows.
And we see it in other trisomies, too, that connect back to that ear and face development.
Absolutely. Trisomy 18, Edwards syndrome, and trisomy 13, Patau syndrome.
Patau is particularly severe when it comes to the face, isn't it?
Yes. Trisomy 13 often presents with severe midline defects, cleft lip, cleft palate, and severe eye defects. In the most extreme cases, the brain fails to divide into 2 hemispheres, a condition called holoprosencephaly.
And there's one more syndrome in this chapter that connects back to that skin and neck discussion we had earlier, Turner syndrome.
Turner's 45X, a female who is missing an X chromosome. And one of the hallmark signs is a webbed neck. Now you have to ask yourself, why is the neck webbed?
It's not just extra skin that grew there for no reason.
No, it's the aftermath of a fluid blockage. During development, the lymphatic system in the neck gets blocked up. This causes a huge fluid-filled swelling called a cystic hygroma. Later, that fluid drains away, but the skin that was stretched out remains, like a deflated balloon. That's the web.
It's all about connecting the dots. You see the web, you think lymphatic blockage, you think Turner's.
It's developmental detective work. You're reconstructing the crime scene based on the clues left behind.
Okay, let's pivot to the final leg of our triple threat. We've talked about how the ear grows and how defects happen. Now, how do we actually see this? We're opening I.B. Singh's Human Embryology, specifically the chapter on ultrasonography.
This is the practical application. Ultrasound is the only reason we know half of this stuff happens in real time, and it all relies on something called the piezoelectric effect.
Which sounds like science fiction, but it's actually just crystal physics.
It is. The transducer probe, the part they put on the belly, contains special crystals. When you hit them with an electric pulse, they vibrate and scream. They let out ultrasonic sound waves way above the range of human hearing.
And those waves travel into the body.
Right. When they hit something, an organ or a bone, they bounce back. The crystal catches that echo and turns the vibration back into electricity. The machine times how long the echo took to return and uses that to build a picture.
So the image on the screen isn't a photograph, it's an echo map.
It's a map of acoustic resistance. And to read it, you have to learn to think in grayscale. You have to know what reflects sound and what lets it pass through.
Let's break down the code. White, gray, and black. What's white?
White is hyperechoic, high echo. This is dense stuff. Bone, fat. Sound hits it and bounces straight back very strongly.
But there's a catch with bone. I.B. Singh points out the acoustic shadow.
This is key. Because bone reflects so well, almost no sound gets through it. So the surface of the bone is bright white, but everything directly behind it is pitch black. It casts a shadow. If you're looking for a heart defect and the baby's arm bone is in the way, you're blind. You have to move the probe to get a different window.
Okay, what's gray on the screen?
Gray is hypoacuic. This is soft tissue, muscle, liver, brain, placenta. Some sound bounces back, some keeps going deeper. You get a textured gray image.
And black?
Black is anechoic, no echo. This is fluid. Sound loves fluid. It travels perfectly through it without bouncing back. So amniotic fluid, blood inside the heart chambers, a full bladder. These look like black holes of the screen.
So if I'm looking for the fetal stomach, I should be looking for a black, fluid-filled circle inside the gray of the abdomen.
Exactly. And if you don't see that black circle at the right gestational age, you start to worry. Maybe the baby isn't swallowing amniotic fluid, and that could be a diagnosis right there, esophageal atresia.
Let's talk about biometry, measuring life. How do we use this echo map to figure out how old the fetus is?
It really depends on when you look. In the first trimester, the gold standard measurement is the CRL, the crown rump length.
That's from the top of the head to the bottom of the butt.
Right. Up to about 12 weeks, this is incredibly accurate.
Mm.
Every embryo grows at almost the exact same rate in the beginning. It's very strictly programmed. So if the CRL is 10 millimeters, we know exactly how many days old it is, give or take just a few days.
But after 12 weeks, that logic breaks down.
The fetus starts to express its own genetics. Some are destined to be tall, some short. Plus, they start curling up, flexing, stretching. You just can't get a reliable straight-line measurement anymore.
So we switch to a composite score. We measure different parts.
Exactly. We measure four main things. BPD, biparietal diameter, which is the width of the head. HC, head circumference. AC, abdominal circumference. And FL, femur length.
And I.B. Singh has a specific note on measuring the femur length that feels like a classic exam trap.
It absolutely is. You measure the length of the diaphysis, the hard ossified shaft of the bone, from the greater trochanter to the lateral epicondyle. You have to see the bright white ends of the bone. But, and this is the trick, you only measure the bright white bone. You do not include the dark cartilage caps at the ends.
And if you do?
If you include the cartilage, you will overestimate the age of the fetus. It's a very common mistake.
That is the kind of detail that really matters. Now, sometimes looking isn't enough. We have ways to get answers that are more invasive than just sound waves. Prenatal diagnosis.
Sometimes you need cells. You need to see the DNA.
Which brings us to amniocentesis.
Right. This is usually done between 14 and 20 weeks. A doctor guides a needle through the mother's abdomen into the uterus and withdraws about 20 milliliters of amniotic fluid.
And what's in that fluid that's so valuable?
Skin cells. The fetus is constantly shedding skin cells into the fluid, just like we do. You can take that fluid, spin those cells down in a centrifuge, culture them, and then look at the chromosomes directly. It's the definitive test for those trisomies we talked about.
But what if you need an answer earlier in the pregnancy?
Then you might do a CVS chorionic villus sampling. You can do this as early as 9 to 12 weeks. You take a literal tiny bite out of the placenta.
Because the placenta and the baby grew from the same fertilized egg.
Exactly. They have the same DNA. It carries a slightly higher risk than an amnio, but it gives you an answer a month earlier, which can be crucial for a family's decision-making.
It is just incredible how much information we can extract. We've gone from a microscopic thickening of skin on day 22, watched it spiral into a cochlea, watched the face assemble itself from shifting arches, classified the physics of how it all breaks, and learned to measure it with basically bat sonar.
It's a heavy lift.
Yeah.
A lot to cover.
So bringing this triple threat together, Langman, Moore, Singh, what's the final takeaway when you put it all together?
For me, it circles back to the environment of the womb. We tend to think of the womb as this, sensory deprivation tank. Quiet, dark, isolated. But the embryology we just discussed tells a very different story.
Oh, so?
Look at the timeline we just laid out. The cochlea is structurally complete and wired up by 20 weeks. The fetus is floating in amniotic fluid, which is a much better conductor of sound than air. It's actually loud in there.
What is it hearing?
The mother's heartbeat is a constant loud rhythm. Her digestion, her blood flow through the great vessels, it's all audible. And her voice. Her voice vibrates through her spine and her pelvis directly into the fetal skull. The sound is conducted right to the inner ear.
So the fetus is listening.
The auditory system is online and being stimulated for months before birth. Those neural pathways are being myelinated based on that input. The baby is learning the rhythm and cadence of its mother's language before it ever takes a breath of air.
That is a wild thought. The learning doesn't start at birth. It starts in the dark.
It starts in the dark and it starts with sound.
Listeners, if you want to see the hillocks of his or truly understand the acoustic shadows, you need to look at the diagrams. Open Langman's chapter on the ear, open I.B. Singh's chapter on ultrasound. These are visual concepts.
Don't just memorize the text. Trace the migration of the tissues with your finger. It makes all the difference in the world.
That's it for this deep dive. We'll catch you on the next one.
Stay curious.